Welcome. We have Dr. Nick Thomas today with us. He's an MD, PhD. He's going to speak about the adult onset type 1 diabetes, insights and unanswered questions. You can see I've put a note in the chat that please feel free to drop questions here. He'll take them as we go, and also as well at the end of the talk. And just a little bit about him, a short bio. He's a diabetes physician and academic clinical lecturer in diabetes and endocrinology at the University of Exeter in England. Type 1 diabetes is known to occur in adults, but classically thought of as a disease of children, and the majority of research is in this age group. So Dr. Thomas's research is looking to improve understanding of type 1 diabetes presentation in adults, and during his PhD, he undertook research looking to better describe the pathophysiology and clinical features of type 1 diabetes presenting in adults, and showed this is both similar and different from when the disease presents in children. He's currently looking to understand how the disease first develops in adults and how we might identify adult cases before the onset of clinical symptoms. And the work has taken on increasing relevance given the new emergence of disease-modifying therapies for early type 1 diabetes. Recent papers include in 2023, the age of diagnosis does not alter the presentation or progression of robustly defined adult onset type 1 diabetes and the challenges of identifying and studying type 1 diabetes in adults. And I will drop those DOI links in the chat in just a second. Welcome, Nick. Thanks so much for joining us.
Well, thank you so much for that really kind introduction, and thank you so much for having me. I think I've got around half an hour. As Monica said, I'm more than happy to be interrupted at any point as we go through.
Sure.
So I'm a type 1 diabetes doctor, and my research interest, Monica said, is mainly around adults. And I probably started looking at this area around 10 years ago. And at that stage, when you read most textbooks around type 1 diabetes, it was mainly thought of as a disease of children, although recognised to present at any age. But actually, some work that I did when I first got interested showed that actually half of type 1 diabetes develops in adults. And what we can see here from this graph is the solid line of type 1 diabetes showing that the incidence is relatively stable across the age of diagnosis, but we've got this dramatic increase in the prevalence of type 2 diabetes with increasing age, so that it predominates later in life. And what that means is that classifying type 1 diabetes later in life is really hard. So we go from a situation in children where if you develop diabetes, you've got essentially type 1 till proven otherwise, obviously rare other causes such as monogenic diabetes, whereas in adults, the vast majority have type 2 diabetes and a very small minority with type 1. We essentially have this situation. Type 1 is easy to spot in children and much, much harder to determine in adults. So again, when I kind of started my PhD, there were a lot of kind of dogmas in the field as to what type 1 diabetes looked like in adults and how it changed in terms of a phenotype with increasing age of diagnosis. So we know from studying children that type 1 diabetes is associated with rapid destruction of beta cells. But it was suggested that in adults, it's a less aggressive disease, you've got slower insulin loss, and therefore it's a less severe presentation and we don't need to worry about it. Also from children, we know that type 1 diabetes associates with islet autoantibodies. But it's been suggested that in adults, those autoantibodies are less frequently found and that antibody-negative type 1 diabetes is more common in adults. And we can see that really well illustrated here in this graph, which was from a study called ADDRESS-2 that I'll talk about a little bit more as we go through. And I just want you to focus on the black bars here because they represent any antibody positivity, so one or more positive antibodies. And what they showed is that antibody positivity in children, young adults, is around 90%. But then you can see it drops off with increasing age of diagnosis. So by the time you're diagnosed 50 or older, around 30% of these adults were antibody negative with type 1 diabetes. And there's also a suggestion that the strong genetic associations that we see for type 1 diabetes in children become weaker with increasing type 2 diabetes genetic overlap with increasing age of diagnosis. But a key point I want to emphasize is that almost all of these assertions are based on a clinician diagnosis of type 1 diabetes.
Can I just quickly ask, in that data
Yeah.
set, did they examine the differences of sexes in presentation? Because I know that's been looked at in children.
No, they didn't, but we can come on a little bit to that, not completely that point. We can discuss that maybe at the end, but a little bit. I do make that point as we go on a little bit about sex and the impact of sex.
Great, thank you.
As I go through, and I'll emphasize that as I go through. So a question then in my brain was, well, do the characteristics of type 1 diabetes change with onset age in adulthood, mainly because biology changes with age? We know from some work again, some nice work from Exeter looking at histology samples from children with type 1 diabetes, that there are differences in the immunology in young children under 7 years of age and older children. So perhaps that's just an extension from this, and we're seeing a markedly different disease process with older age of onset. But the alternative is that actually in adults and with increasing age of diagnosis in adults, misclassification becomes more common. So we're inadvertently including more individuals in our cohort that we're studying that don't actually have type 1 diabetes, and therefore diluting the phenotype that we're observing. And I've already shown you this slide just to highlight how difficult type 1 diabetes diagnosis is in adults. And actually we can see that play out with some more data from a really elegant study that was done in Scotland a few years ago now by Fontenopoulou and colleagues. And what they did is take their entire type 1 diabetes clinic in Scotland and said, let's confirm the diagnosis of type 1 diabetes using biomarkers, including C-peptide. And what they showed is that those diagnosed in childhood, indeed almost all of them, had type 1 diabetes, well over sort of 98%. Whereas with increasing age diagnosis, you can see that this in black, so this is type 1 diabetes, that percentage with confirmed type 1 diabetes starts to reduce. So much so that by the time those are diagnosed over 30, they reclassified 14% of that age group. And the vast majority, they did testing for monogenic diabetes in those that they were reclassifying. And they found a handful of cases, but by far and large, this grey colour is type 2 diabetes. The vast majority were felt to have type 2 diabetes. And importantly, a proportion around 25% were able to come off insulin without any deterioration in their glycemic control. So a real benefit to reclassifying for patients, which again, I'll come on to. But when we're still thinking about the phenotype of type 1 diabetes in adulthood, if we've inadvertently included some misclassification, let's just give another example of this. So many of you will be aware of some of the genetic risk factors that increase your risk of developing type 1 diabetes, particularly driven by HLA, the classical DR3, DR4. But perhaps less well known, although I'm sure many of you will be familiar, there are actually protective HLA that decrease your risk of developing type 1 diabetes. And the most well known of these is HLA DR15. And that's present in around 20% of the European population. But it's incredibly rare in children with type 1 diabetes because it's protective against type 1, so less than 2% of children. But the vast majority of literature has suggested that this DR15 protection is attenuated with increasing age and then lost in older adults. But there is one study that suggested that DR15 protection actually was maintained throughout life. And this really matters because if we're thinking of understanding mechanisms of why this DR15 is protective, there's a big difference between something that's almost a genetic vaccine against type 1 diabetes for the entirety of life versus something that has a marked effect in children that perhaps then reduces, and then those children that were those individuals protected in childhood then go on to develop it later in life. But actually the key difference in these studies was how type 1 diabetes cases were defined. And that kind of makes sense because if we've inadvertently included, say, 14% from that Fontenopoulou study who were clinically diagnosed with type 1, so that's the majority of the literature, but actually don't have type 1 diabetes, then you can see how that proportion of individuals who would have a population rate of HLA-DR15, you can see that you would then start to see an increased risk rate of HLA-DR15 in your adults with increasing age as you increasingly included non-type 1 diabetes. So just before we move on to some up-to-date data, we should probably touch on LADA, because I'm sure some of you will be thinking, well, what about LADA? What about latent autoimmune diabetes of adults? Where does this fit in? So first of all, it's worth just pointing out what LADA is in terms of the definition. It's traditionally thought of as diabetes diagnosed over 30 years of age, associated with positive islet autoantibodies, most typically would be GAD, and the absence of insulin requirement for at least 6 months after diagnosis. And when you look at the literature in this area, the characteristics of LADA are broadly reported to be intermediate to type 1 and type 2. They can vary depending on age of diagnosis and GAD titer used, but they're largely both genetics, progression, said to kind of reflect a kind of intermediate phenotype. So I think the majority of you are in the States, and therefore it's probably a lot earlier than it is here. And so you can probably handle a tiny bit of maths, but apology for those who it's after 5 p.m. in the UK. But this is a well-recognized equation for working out the positive predictive value of a test. And a key thing I want to draw your attention to is that word that features both as the numerator and the denominator, which is prevalence. So if we take an assay GAD that has a 97.5% specificity, because that's how we define it based on a population, that will be 80% sensitive. So it will detect 80% of individuals with type 1 diabetes. Now, if we look down the bottom end of this graph in those that are diagnosed in childhood, I've already said that around 95% plus of those with diabetes are going to have autoimmune diabetes. So if we do a GAD assay in those individuals, the positive predictive value of that test is near perfect. It's not quite 100%, but not far off. Conversely, if we apply the same test, but this time in an individual diagnosed at 50, where the prevalence of type 1 diabetes is less than 5%, then we see an altogether different situation. So if we take 100 people with diabetes and test GAD in all of them, if we take 100 people with diabetes, we can anticipate based on 5% having type 1 diabetes that 5 will have type 1 and 95 will have type 2. And then if we test GAD in all of them, what we'll find is that because we've got an 80% sensitivity, then 5 of those 5 type 1s, 4 will be GAD positive because it's 80%. But then if we take 2.5% of our 95, that still gives us 2 individuals who don't have autoimmune disease, diabetes, but will be GAD positive. So then in that scenario, of our 100 individuals, we've got 4 who have type 1 who are GAD positive, 1 who obviously has type 1 that's GAD negative, and 2, importantly, who have type 2 but are GAD positive. And so that now gives us a positive predictive value of 66%. And of course, actually, when we're increasing age, that prevalence of autoimmune diabetes is probably considerably less than 5%, and therefore that positive predictive value is only going to reduce. And in fact, we can see that in data. So if we look on the left of this graph here, in a control population without diabetes, and we do GAD based on the same assay sensitivity and specificity that I've just shown you, well, based on that 97.5% specificity, 2.5% of the population are GAD positive, as we would expect. These are people without diabetes. And we can take it even further, and we can test people with genetically confirmed monogenic diabetes. And indeed, again, 2.5% of them will have a positive GAD, again, in keeping with the specificity of the assay. Now, if we test patients with adult onset type 2 diabetes who haven't yet progressed to insulin, so these would fit with our LADA if they were GAD positive, well, when we test those individuals, we find around 5% are GAD positive, so clearly higher than that 2.5%. But the question is, these 5% all represent one phenotype, one diabetes type, which is LADA, or in fact, are we seeing 2.5% that reflect the positives that I've just shown that we see in monogenic and the control population, with an added 2.5% that actually have type 1 diabetes that haven't been recognized at diagnosis? And I'll come on to those as we go on.
I'm sorry, Could you please clarify? When we have islet autoantibodies in patients with type 2 diabetes, is the mistake of the protocol that you use for finding these antibodies, or really there are like some patients with type 2 diabetes that have autoimmunity?
It's a good question. So I think a bit of both. So the first thing I would say is that my practice is not to test antibodies where I don't have a suspicion of type 1 diabetes. And I'll come on to where I do test antibodies, because the problem is once you've tested them and found them, you then have to explain them away. But if you do find the scenario where you have antibodies, then if you had a population, what I'm saying is that I think it represents two types of things that's going on. I think there are people that have type 2 diabetes that have a positive antibody. That antibody is not impacting the pathophysiology of their diabetes. They have type 2 diabetes, but have an incidental antibody that hits the specificity of the test, in keeping with these patients with monogenic, where their diabetes is not influenced by the antibody they have. And obviously people without diabetes, who obviously the antibody isn't causing diabetes because they don't have it. And then you've got this additional cohort that have type 1 diabetes that hasn't been picked up at diagnosis, because diagnosing type 1 in adults is really hard. And I'll come on, I've talked mainly about type 1 that's not type 1, but I'll come on to patients who are thought to have type 2 where actually they might have type 1. But in this cohort, they probably do have true type 1 diabetes. And I'll come on to a little bit how I think you can start differentiating. But the take home for now is that I think this cohort represents two different types: true type 1 that's been missed, and then antibody positive type 2, where the antibody is not causing their the pathophysiology of their diabetes. So thinking now about what the true characteristics, and this is the kind of main theme of my PhD, is, well, we've got this difficulty diagnosing type 1 diabetes in adults, and we think there might be problems with how we've studied cohorts to date based on clinical diagnosis. So what do the true characteristics look like when we define robustly? Is it that there's a completely different biology, or is it actually that type 1 looks much more similar in adults to childhood than previously suggested? So throughout, I'm going to use two high specificity type 1 definitions. So the first, and a key point to this, is it's agnostic of clinical diagnosis. So it allows us to study what patients' characteristics look like, because the problem, as soon as you include a clinician diagnosis, is you're biased to what clinicians thought. So we just use multi-antibody positivity in the context of diabetes of any type. And that's because we know from children that multi-antibody positivity is highly specific for type 1 diabetes. And the second definition is a clinician diagnosis confirmed by at least one positive autoantibody. And I just wanted to point out the importance once again is that we're trying to eliminate obviously this 14% that are misclassified that might be diluting the phenotype. The other reason for showing this graph is that whilst I've said that 14% are reclassified, clinician diagnosis is pretty good. So when we think back to that positive predictive value, our prevalence when we're studying clinician diagnosed is really high. And even in these adults, it's going to be 86%. So then any confirmation, antibodies, etc., in the context of a clinical diagnosis is again highly specific, because if we remember back to that equation, it's all about prevalence. And our prevalence of type 1, even though it's not perfect and it has an impact for studying the disease and on these patients, it's still considerably higher than the 5% if we just looked at the cohort, if that makes sense. So the studies that that I'm going to describe, and I've alluded to address 2 already, is address 2 and start right. So address 2 was clinician diagnosed type 1 diabetes recruited from across the UK, and there's just under 2,000 individuals. And they were aged 4 to 75 at diagnosis and were recruited within 6 months of diagnosis. And a key point is that all of them had islet autoantibodies measured at recruitment, so within 6 months. So that's GAD, zinc, NIA2A. They didn't do insulin antibody because insulin antibody becomes inaccurate once individuals are treated with insulin, which obviously the vast majority or all of these individuals were because they were clinically diagnosed with type 1. The second study is StartRight. So that was, again, a multi-centre study in the UK based out of Exeter. That was around 1,800 diabetes cases. And this time they were any diagnosis of diabetes. So that included type 2, some monogenic and some 3C type diabetes. They were all aged, they were all in adulthood at diagnosis and recruited within a year of diagnosis. And again, all had GAD, zinc, and IA2 measured. And then additionally, urine C-peptide was measured at recruitment, year 1 and year 2. And it was a 3-year study, and it's just finished, and the final write-up at the 3-year endpoint is ongoing. So the first thing to say is that insulin loss in adult onset type 1 diabetes is rapid. So this is from StartRight, where we had measures of C-peptide at different time points. And this is where type 1 diabetes was defined by multi-antibody positivity in adulthood, irrespective of clinician diagnosis. And what you can see is that with increasing age of diagnosis in adults, there is no difference in the rate of progression. And that actually the rate of progression is rapid. So losing around 40% of their C-peptide a year. And just to put that into context, it is slightly slower than the rate that's kind of reported in the literature in children, which is around 50%. But it's still, to my mind, rapid and clearly much more progressive than we see in those with type 2 diabetes. And actually, we also looked with a second definition, which was a clinical type 1 diabetes diagnosis plus a single positive antibody. So this is in the same data set, selecting an entire different cohort of patients. And what you can see here is that the result is almost exactly the same. So no difference of age of onset, and again, around 40% loss of C-peptide a year. So just to be clear, these two graphs are showing this, are showing the same thing, but with completely different cohorts and showing around 40% loss in adults. And then in the same cohort, in the multi-antibody positive individuals, we wanted to look at what their clinical presentation looked like at diagnosis. So this time, as I said, we've used the multi-antibody positive because that's irrespective of clinician diagnosis. So we don't have the problem of having an enrichment for what clinicians thought. And what you can see here, it's certainly in the top two groups, is that by and large, presentation is very similar. So symptoms are severe, irrespective of age of diagnosis. You're still seeing 20% of those adults diagnosed over 35 presenting in ketoacidosis, high rates of osmotic symptoms and weight loss. There's marked dysglycemia in both groups, presenting with a mean HbA1c over 100. Sorry, that's in millimoles a mole, and a glucose at diagnosis of around 21. But the key difference with how these patients were actually managed. So if you were diagnosed older, you were far less likely to be admitted, far less likely to start insulin at diagnosis. So a quarter of those diagnosed over 35 didn't start insulin at diagnosis, and 30% were treated with other non-insulin based therapies. And in fact, that's this difference in management and treatment is something that we've seen before. And this, as I alluded to earlier, is a reflection and partially what the question kind of alluded to, is because diagnosis of type 1 diabetes in adults is hard, not only do we have patients with type 1 clinically diagnosed with type 1 who probably don't have type 1, we've also got people with type 2 diabetes who probably actually have type 1 diabetes. And so this was a study where we looked locally called DARE. And what we did is in patients with established diabetes within our cohort, we classified them based on C-peptide with severe endogenous insulin deficiency defined based on the C-peptide of less than 200 over 3 years duration. And what you can see here is that around a third of those diagnosed in adulthood didn't start insulin at diagnosis. So this was a slightly different cohort, but not that far off what we saw in the StartRight study. What I really wanted to emphasize was, even though this self-reported type 2 diabetes, this self-report diabetes type was done at study recruitment, where most of these individuals had, or the mean duration of these individuals was around 17 years, half of these individuals were still reporting type 2 diabetes. So they were still being treated and managed as though they had type 2 diabetes, even though they had severe insulin deficiency. And you can see that the majority of them were antibody positive, so they do have type 1 diabetes. So clearly, this absence of recognition of type 1 diabetes is important.
Nick, quick question from the chat from Peter LaMedica. Longitudinal studies of pediatric T1D autoimmunity have been really informative. RE, the rate of progression to stage 3 disease with 100% of stage 1 subjects eventually progressing over a 15 to 20-year period. Are there any longitudinal studies ongoing looking at adult onset T1D autoimmunity?
It's a question very close to my heart, because I've got an interview in 2 weeks' time where I'm proposing exactly that, because the answer is no. We don't have that data. There's a handful of patients from TrialNet, obviously massively enriched for family history, with quite small numbers, but we don't have big population data, and that's something I want to look into to understand. So we don't know what the natural history of type 1 diabetes pre-clinical diagnosis looks like in adults, but it's a question I really want to answer. So thank you for highlighting that. And when we looked in this same DARE study, what we saw, and this kind of comes on to the question that I was asked previously around those thought to have type 2, is that a key differentiator in type 1 diabetes is rapid progression to insulin. So what we found consistently really in the studies that we've seen is that the vast majority of those with type 1 diabetes are progressing to insulin within a year of diagnosis, and almost all within 3. And the reason for that kind of makes sense. If we've shown that the loss of C-peptide is around 40% a year, then there gets to a point where the only treatment is insulin that these patients can have to keep their HbA1c, their blood glucose, in check. And indeed, I think this is really emphasised well by our Prime Minister, Theresa May. So Theresa May was diagnosed, and this is widely available. This isn't from me having any involvement in her care, but she was diagnosed in her 50s with diabetes, thought to have type 2 diabetes, treated with traditional type 2 therapies, and despite that, just became sicker and sicker, was losing loads of weight, was put down to where, at that stage, she was thinking about becoming Prime Minister, so just thought that she was kind of preparing herself for that. And then eventually she ended up on insulin as the only thing to manage her blood sugar, and then was recognised with autoantibody testing that she actually had type 1 diabetes. And kind of to look at this kind of idea a bit more in depth, one of my colleagues, Vince Simpson here in Exeter, again took the StartRight study, and he said, well, let's look at those patients with type 2 diabetes who during the StartRight study have progressed onto insulin. Can autoantibodies, can they help us differentiate exactly that question that I was asked? Can they help us differentiate those people who we think probably actually have type 1 diabetes and have just been missed? And here we can see that the answer is probably yes. So I want to draw your attention to the orange line. So these are patients with type 2 diabetes diagnosed clinically who are antibody positive and have rapidly progressed to insulin. And what you can see is that although they're starting from a slightly different C-peptide from those with classical type 1 diabetes, as I've already described how they were defined, we can see that their rate of loss of C-peptide is almost identical. And that is in contrast to those who were rapidly progressing to insulin but were antibody negative with that same clinical diagnosis. So there's a different pathophysiology going on here. And indeed, then when we look at genetics, we can see again that this plays out, strongly suggesting that these antibody positive in the context of rapid progression to insulin is indeed picking out type 1 diabetes, because you can see their genetic risk in terms of both genetic risk for type 1 on the y-axis and type 2 on the x-axis is near identical to classic type 1 diabetes, where conversely, those with type 2 diabetes who are antibody negative despite rapid progression to insulin have genetic risk that's comparable to type 2 diabetes. I'd also like to draw your attention to the remaining cohort that would be LADA. So that's people with type 2 diabetes who haven't yet progressed to insulin but are antibody positive. And again, you can see their genetic risk is clustering around that for type 2 diabetes. So again, going back to that point earlier, this could be one phenotype, or actually, as the genetics is suggesting, perhaps this is clustering out to be two different diseases where we've got type 1 diabetes and type 2 diabetes within that antibody positive diagnosed as type 2, not immediately starting insulin definition. Fine, so I'm going to come back now onto this idea of reducing antibody positivity. So as I alluded to, and I've shown this graph already, this is from the ADDRESS 2 study, and this was testing antibodies in all those with the clinical diagnosis, and I've already shown that 30% of those over 50, based on this study, were felt to be antibody negative. But alongside my colleague, Dr. Kash Patel, we asked the question, well, actually, do we think all these individuals definitely have type 1 diabetes? Or is it perhaps, again, that we've got some increasing prevalence of non-type 1 diabetes within those adults, and particularly with increasing age of diagnosis, which we wouldn't anticipate being associated with antibodies, and that's why we're seeing that reduction. So the question we asked was, well, if all of these individuals have type 1 diabetes, then we would expect their genetic predisposition to look like type 1 diabetes, irrespective of their antibody status. And indeed, we see that in children. So here you can see that the antibody positive children and the antibody negative children have the same genetic predisposition for type 1 diabetes. This is a slightly different graph than previous, that we've now got HLA type 1 risk on the y-axis and non-HLA type 1 risk on the x-axis, but we can see this clustering irrespective of antibody status in children, in keeping with what we know, that around 10% of children are antibody negative, and a wide differentiation from type 2 diabetes. And when we look at adults who are antibody positive, they too cluster around our type 1 children. Now, there's a slight reduction in HLA associated risk that's been reported previously. It's very mild. It's certainly significantly still different from type 2 diabetes, and they've got high genetic predisposition for type 1. Conversely, when we look at adults, we can see a marked reduction in both HLA and non-HLA driven risk for type 1 diabetes, and it's being pulled down much closer to type 2 diabetes. And so what we thought was, well, this probably means that the majority, not all, clearly some of these individuals who are antibody negative and clinically thought to have type 1 do have type 1 diabetes, because their genetics isn't identical to type 2, but it's certainly not the same as the antibody positive. And what we did was we tested for monogenic diabetes, and indeed found some cases which sort of gave us a kind of proof of principle. So we found around 4% of those antibody negative adults had monogenic diabetes. And then we used a genetic method that we'd used previously to estimate, based on where the genetic risk lay for these antibody negative adults, what proportion we thought had type 1 versus type 2 to explain this difference. And we found that it was around 2/3 had non-type 1 diabetes. And we wanted to have a slightly closer look at this. So we wanted to have a look at what the characteristics of these antibody negative versus positive individuals look like. Now, it's really worth emphasizing here, as I've already mentioned, that when you're selecting patients based on clinical diagnosis, which we're doing here for the whole of this study, then you're going to get characteristics that look more marked than perhaps we'd suspect with, non-type 1 diabetes, because someone somewhere has had to think that they've got type 1 diabetes. And this is just where I was going to emphasize the sex difference. So you see a higher proportion of male in those that are antibody negative. And this fits for me because we know that women develop type 2 diabetes at a higher BMI than males, because of their ability to store fat. And so my suspicion is, and we can see that in the BMI difference again down here, is that probably reflects the fact that males perhaps look more atypical for type 2 diabetes than females. But a key difference I wanted to draw your attention to are these bottom two lines. So first of all, those who are antibody negative are far less likely to have another autoimmune disease. But perhaps most striking is that they're more likely to have a parent with diabetes. And this intrinsically doesn't make sense to me, because we've shown that their genetic risk is lower than those who are antibody positive, and yet they're more likely to have a parent with diabetes. And yet we know that type 2 diabetes has an increased family inheritance compared to type 1. And we also know that if you've got higher genetic predisposition to type 2 diabetes, that you can develop it at a lower BMI and perhaps at a younger age. So again, sort of makes sense, but it intuitively doesn't make sense if we're saying that all these patients have type 1 diabetes. So what we did then is we said, well, if 2/3 of those who are antibody negative in older adulthood don't actually have the disease, what would the antibody prevalence look like if we adjusted out that proportion? And it looks like this. And so again, in black, we can see now that irrespective of age of diagnosis, the rates and the prevalence of autoantibody positivity is the same in terms of around 90%. But there are key differences. So those diagnosed older are almost all GAD positive, whereas there is a more even distribution in those diagnosed in childhood. And we can see that the rates of IA2 and zinc transporter 8 positivity reduce with increasing age of diagnosis. Now, I've sort of by and large, really talked about the kind of impact in terms of understanding the disease, which is one of the key focuses of my PhD. But obviously there are patients in the middle of all of this. And so getting the right diagnosis is obviously really important for them. We've obviously touched on people diagnosed with type 2 who didn't initially get insulin and then have rapidly failed their type 2 therapies. But we've also got individuals with type 1 who we think probably don't have type 1 diabetes. And so my colleague Russell Eason wanted to explore this and see what the clinical impact of feeding back an antibody result in a new diagnosis of type 1 was in terms of their treatment. And so again, this is from the StartRight study. So we've got the individuals with type 1 defined in the ways that I've already described in red. And then we've got this cohort largely mirroring what we saw in ADDRESS 2, who are antibody negative, clinically thought to have type 1, who've got intermediate risk for type 1 diabetes. So it's reduced and actually closer to type 2, suggesting that the majority of these individuals could well not have type 1 diabetes. And he also looked at their rate of progression and C-peptide loss over time as a cohort. And you can see that it's markedly reduced compared to that group with type 1, who I've already shown you are around 40%. Now, it's clearly faster than those who with type 2 are antibody negative, suggesting that indeed there is probably some type 1 in this group, around 1/3, as we saw in the ADDRESS 2 study, but that still the majority probably don't have type 1 diabetes. And so what he did was to evaluate the clinical impact of feeding back these autoantibody results on the patient's management, and then importantly, their glucose control. And so I want you to concentrate on this side, the left-hand side as you're looking at. These are individuals with a clinical diagnosis of type 1 who were found to be autoantibody negative, and that result was fed back. And of those 164, around a quarter stopped insulin, another 14% had a non-insulin therapy added. And what we can see here, when we look at the follow-up HbA1c, which was around 2 years duration, is that despite stopping insulin, these individuals, and so the most recent is the open square, these individuals had good glycemic control comparable to the other groups who either continued insulin or had another therapy added, suggesting that it's safe to stop insulin and that you can stop insulin in these antibody negative, making sure they're on the right treatment for their diabetes. So just to
a
finish
quick-
up,
Oh, sorry,
yes.
just was gonna insert this. A question has been waiting for you, and I just wanted to sort of like capture it. Peter Lemedico again, experts agree that T1D autoantibodies are a good biomarker for ongoing autoimmunity, but are not pathogenic. How about a simple hypothesis? Autoimmunity in both pediatric and adult onset T1D are similar, with autoantibodies being a good early biomarker for ongoing autoimmunity, but in a time-dependent fashion. In parentheses, mechanism, question mark. There is a reduction in these circulating T1D autoantibodies in both pediatric and adult onset T1D. It sounds like Dr. Thomas is discussing this question at the current time in his presentation, so possibly if we wait, he'll provide his bottom line viewpoint.
Yeah, I'll come on to my bottom line viewpoint. I think just to summarize, and perhaps we'll have time for a discussion at the end if I've got this wrong, but we do know that antibodies reduce with onset. Typically, the most resistant to that, for want of a better word, is GAD, which tends to stay around for a bit longer. And certainly we're seeing in our cohorts, the vast majority are GAD. And if I went back, I won't go back now, but if I go back to the DARE data, it was around 75% of those who were C-peptide negative still had antibodies at 17 years duration. So, and remembering that we're talking here about absent antibodies rather than antibodies that are very close to diagnosis. So both address 2 and start right were within a year of diagnosis. So I personally don't think that explains this. That difference, and as I said, if anything, we'd expect it to be less marked than in children, not explaining a 10% in children to 30% in adults difference. But it is of course a valid point. So just to finish up before we can open up to hopefully some good discussion, is to answer this DR15 protection question, which, as I said, is really important if we're thinking about the mechanisms of type 1. And so what we did again in the DRESS2 cohort was we looked at DR15 when we defined by clinical diagnosis confirmed by a positive antibody. And what we can see in the blue lines is that indeed there's a slight attenuation, but actually protection is still maintained in those diagnosed between 30 and 15, suggesting that this protection isn't just wearing off with increasing age of diagnosis. And as I suspected, that those previously reported findings probably most likely reflect misclassification rather than true biology. So just to summarize and finish, what I've hopefully shown from my point of view is that actually type 1 diabetes in adults is rapidly progressive and does present severely. And the main difference that we observed in the Start Right study was actually how it's managed by clinicians. That type 1 diabetes does associate with islet autoantibodies, and that when you adjust out that proportion that we don't think have type 1 diabetes, you see an equal percentage that are antibody positive, and that type 1 diabetes in adults does have genetic risk, and that protection is maintained. I think it's worth pointing out there are subtle differences between adult and childhood onset cases. I've shown you that the HLA risk was slightly lower. I've shown that the progression perhaps is slightly less rapid. And we know that there's heterogeneity within adult onset cases. So, there are individuals in my clinic that are multi-antibody positive that are progressing less rapidly. But we see that in adult and childhood onset cases. And I think my leaving point would be that there are far more similarities between adult onset type 1 diabetes and childhood type 1 diabetes than there are differences when we get over this classification issue. But just to leave you with some final clinical take-home messages, which I certainly practice in my type 1 clinic, is to reiterate that diagnosis is hard. So this isn't a failing of us as clinicians. It's just really hard to classify diabetes in adults. And therefore, we should just test autoantibodies in all adults we suspect to have type 1 diabetes, irrespective of how confident we are. And additionally, we should also test autoantibodies in anyone rapidly requiring insulin, because as I've shown, that will capture those that actually have type 1 diabetes rather than type 2. But but where we have a clinical diagnosis of type 1 diabetes, a positive antibody, as I've shown, will confirm your clinical diagnosis. So you can be quite happy at that stage. Then my practice, certainly, and this is reflected in ADA and ESD guidance, is that where you've got individuals who you think have type 1 but are antibody negative, then we reevaluate that diagnosis. So at a minimum, I would be suggesting C-peptide testing at 3 years duration. If you're fairly confident they have type 1, then you can continue insulin at that stage, and then wait for the C-peptide at 3 years. Or as my practice is to do serial C-peptide perhaps every year, and then have the discussion with the patient, perhaps start thinking about introducing non-insulin based therapies and cautious withdrawal of insulin early with close follow-up. So I'm just going to stop there and thank you all for listening. It goes without saying that, none of this would be possible without the support of all my collaborators, co-authors, PhD supervisors, but mainly all the patients, staff and sites that made these 2 studies that I've shown you possible. Thank you for listening, and it'd be great to have a bit more discussion.
Yeah, this is fascinating. You're really kind of unearthing. It's almost like an archaeological dig here. You're unearthing, sort of a previous understood way of diagnosing people and really digging into it. I think it's so important. Here's a question from Alexis Karmer. Notice the y-axis on one of your slides was urine C-peptide or urine C-peptide / CR ratio. Is there any role for stimulated C-peptide testing for diagnosis in adults, or is fasting / random adequate?
It's a really good question. Thank you. So for clinical practice, I don't think it matters, because what we're looking for is multifold differences. Because if you think about it, we're looking for C-peptides to say that someone's severely insulin deficient. And ultimately, what we're really doing C-peptide for at 3 years duration is to think about diabetes type, but ultimately what treatment do they need? So are they severely insulin deficient and therefore definitely need to continue insulin, where we would tend to use a C-peptide under 200? Or have they got marked retained insulin secretion and a C-peptide, we say over 600, but really in kind of 3 years, 4 years duration, non-type 1, we're expecting a C-peptide up in the thousands. So we're talking about 5-fold differences. So we tend to do, for ease, I would generally do a random serum C-peptide, because I can get that. We've shown that is stable. I can do that in clinic when I see patients. Then obviously if there's uncertainty and they're in that grey area, kind of between 200 and 600, then I might think about doing more formal testing. But generally speaking, you're seeing marked differences where, the clear type 1s have got almost double-digit C-peptides. And then, as I say, we're looking for values over 600, but often they're in the over 1,000 picomoles when we're dealing with non-type 1. The reason that some of those graphs have different things is just for ease of conducting clinical studies. So this was a multi-center study that we wanted to do serial follow-up of patients over time across 3 years. So urine is super stable. This was being conducted in the middle of a pandemic, so it was much easier to get a urine sample off a patient than trying to get C-peptide from blood, although we have managed to work up for a study that again has just finished, doing remote capillary C-peptide testing, which is something we're looking at bringing in clinically for testing a whole clinic in one go, because again, you can do that remotely. But yeah, for clinical practice, I just tend to do, first and foremost, a random.
Thank you for answering that. Speaking of the pandemic, have you noticed sort of an uptick in adult T1D diagnosis post SARS-CoV-2? I mean, I don't know if it could be anecdotally for just sort of your clinic, but I mean, just if you have your finger on the wire across clinics, is that something that people are looking at?
Yeah. So again, really nice, question. Anecdotally, no. And I do think, and again, it comes back to an earlier question, I think, Peter, about the natural history. And we know from kids that there's dysglycemia prior to the diagnosis of type 1, and that we know that if you stress someone's body and you increase their insulin resistance with an infection, say, then they're going to get dysglycemia earlier. So I suspect we unearthed more cases, and there has been a suggestion sort of across in the Scottish data about that. But I think we need to follow that up over time to see whether, as I suspect, the prevalence will then, will drop a few years after that to then equivalent out. So anecdotally, no, I think we need most of the big data sets that we use, such as CPRD, which is a primary care data set here, general practice, there's a lag of a few years to get that data. So I think we need to look at it, but my gut feeling is that we just unearthed cases earlier. And that will kind of work if you think about, again, back to the kids that we're talking about, that autoimmunity starting a good few years before diagnosis. So really, if we are going to see a prevalence effect, in my brain, it might be in a few years' time that we start to notice it. Yeah. So I think that would be my, there's not a huge amount of data there, but kind of anecdotally thinking about it, that's what I've kind of concluded, that it doesn't seem as likely to me. And I think it's more an unearthing than an actual cause of the COVID.
Yeah, I think, well, it's going to be discussed. I think Mark Atkinson and others are going to discuss it at ADA, so that'll be interesting. I think it's the last day. Peter Lomedico, do you want to unmute yourself and just sort of like talk your question through? Oh, wait, maybe he's not here anymore. He's not here. May have had a time crunch. But yeah, he's just, his question is very long.
What I might stop sharing if that's okay, and I might.
Yeah, sure. Yeah. And do you want to look at the question and
look
answer?
at the chat? Yeah, I can. Yeah, so I think what his point is driving at is what I've sort of answered when you first mentioned it, which is that perhaps in adults you're seeing more antibodies falling off quicker than in kids. And one of the questions I always get asked about this, and I think it's human nature, is to think of alternative explanations is exactly that. So they've got type 1, but either they've lost their antibodies or they've got other antibodies you don't know about or that you haven't tested. And it's plausible. Can I say that they don't know? But what I would say is, for that to be true, those ones that lost antibodies only in adults, not in children, would have to be associated with a different genetic predisposition, because we showed the risk reduced. And also, if it's an antibody we don't know about, then it would only be present in adults, and it would become more common with increasing age of diagnosis. To me, that seems less logically likely than the fact that clinicians might not be perfect in a scenario where it's really difficult. So I think it is hard to say, well, actually, maybe we're not perfect at diagnosis, but that's why I always start with, it's really hard. You're trying to pick out, and I think that, that Where's Waldo as you know it, Where's Wally as I know it image kind of really reflects that it is really hard when you're looking for something that's in the minority. And we know that with increasing age of diagnosis, type 2 diabetes tends to happen in people who are slimmer, and perhaps with a more insulin deficient phenotype, suggesting that it is, that would be easier to get that diagnosis wrong. And I think it's also worth saying that we're, a tiny percentage of type 2 is atypical, perhaps. Say if you had 100 people with type 2, 1 or 2 of them might be very slim with a more insulin deficient picture. But because that's 2 out of 100, and we're only saying that kind of 2 or 3 of type 1s in that age group, of all diabetes in that age group, would be type 1, you're kind of 50-50. So it is really, really hard. And I think, it's also really reassuring that some of these patients can stop insulin. And those ones that I showed, that 25%, they've maintained off insulin for 3 or 4 years with stable blood glucose control. So I really don't think they have type 1 diabetes. I think they have atypical, type 2. So I think it's important question to think about. Can I definitively say it's not? No. But do I strongly believe that it isn't some strange antibody negative type 1? Yes, I don't think it is. I think this is type 2 that's been missed because the diagnosis is really hard.
And so, yeah, that is really, it's a complex, it's really a complex issue. But I do think that, you know, your group at Exeter and England are sort of starting to lead the way in pushing into this. And I guess I would ask, how can the medical community become more proactive in adult screening for T1D, and what's happening in England or in the UK that's driving that?
You mean screening for type 1 or diagnosing or classifying at diagnosis?
Yeah, I mean maybe both, but classifying as an adult for adults.
Yeah, so I think one of the key messages that I like to get across, and that's why I say it lots, is it's hard. And I think if you start at a point of uncertainty, then are using as we do in medicine always, you know, we have a differential diagnosis and we then use biomarkers investigations to confirm or refute that diagnosis. But in children, we don't need to do that because they've almost all got type 1 diabetes. So, you know, it's a slightly alien concept when we come into adults. But really what we're saying is they've got diabetes. They presented severely. Which type do we think they have? We think probably type 1. So let's do antibodies. And where they've got antibodies, we're home and dry, we're hosed. And I've already said 90% will. So you're going to confirm the diagnosis in the true ones 90% of the time. And then those ones that don't, it's just keeping an open mind, going back to the diagnosis and going, well, in retrospect, what do I actually think now I've got this added bit of information? Do I think actually, you know, there are some other things going for type 2, perhaps they've got a strong family history, et cetera, et cetera. Maybe actually I'm okay to keep a close eye on them, stop insulin, start type 1 therapies and just keep a close eye and monitor. Or perhaps no, I'm still convinced they've got type 1, they've got a positive type 1 family history, they've got other autoimmune diseases. Fine, I'll keep them on insulin, I'll keep them on follow-up, but at 3 years, I will test their C-peptide without fail to check what it is. And if they've got marked retained C-peptide, then I'm going to think about withdrawing insulin or alternative therapies, maybe if I'm not comfortable stopping insulin at that stage. So I think that's the real key, is to have uncertainty as we do in other aspects of medicine. And what we're trying to look at is if we can develop prediction models, rather like the Modi calculator that people on this call might be familiar with, to try and give, you know, the clinician diagnosis, which the other thing is it varies from person. So what I think might be barn door type 1, someone else might not think is type 1 and vice versa. So it tries to unify what we think is likely type 1, and then we'll modify that risk based on antibody status, etc., moving forward. So we're kind of trying to formalize things a little bit and make it life a little bit easier for people without that kind of uncertainty of, oh, have I got it right or wrong? Where, you know, I'm not going to get tired of saying it. It's really hard. And, you know, we shouldn't be afraid to recognize that.
Well, I think this talk will land very well on our clinical audience, especially in the trainee audience. And we look forward to having those individuals view it here in the States and across the globe. So thank you so much for sharing this. It was a really interesting talk, and
thank you so much for having me.
Great. Thanks for going over too. I appreciate it.
No, it's all right. Just to leave to say there were questions, and you kind of alluded to screening, and that's something certainly I'm looking at and moving towards. And so hopefully in a few years' time, I can come back and update you where we do know what the natural history looks like, and we do have some thoughts about how we might pick up early type 1 in adults to benefit from teplizumab, etc., and hopefully new therapies.
That sounds great. Thanks again for joining us in this evening, and we'll speak to you again in the future soon, I hope. Have a great evening.